welcome all. We'll just take a minute or so just to have you all join. So please do pop in your chat box a little introduction to yourself, who you are, where you are, and maybe your role. And we look forward to getting started just in a minute or so. But we'll just take a few moments to have you all join. Great to see the rich array of people that are gathering here with us for this MAMI side event. So thank you so much for making the time to join us. As I say, please do introduce yourselves in the chat box, who you are, where you are, and your role, and we'll get started very, very soon. Lovely to see you all joining. And thank you for making all the introductions and connecting together over the chat box. It's a shame we can't be together in person, but let's try and make it as close as possible to the real thing. I'll just take a couple of moments more, as I'm keen for people to be in from the beginning, but also we have a rich program ahead and a tight agenda. So I think what we'll do is we'll probably get started and people will continue to join. So Fáilte, and welcome one and all of you today to this N4G side event on how we can partner and collaborate to co-create evidence to transform the care of small and or nutritionally at-risk infants under 6 months and their mothers. In other words, MAMI. My name is Marie McGrath. I am a technical director at ENN and co-chair of the MAMI Global Network. I'd like to begin by extending warm thanks to the government of Japan for their accommodating and endorsing of this official N4G event, and to the Eleanor Crook Foundation and Irish Aid, who have resourced and supported ENN and the MAMI Global Network to gather us all here today in preparation for this critical build-up to the N4G Summit in December. Indeed, it is the strategic vision and savvy long-term investments by ECF and Irish Aid on MAMI that we can draw much inspiration from when it comes to developing quality evidence to help shape policy. More on that later, but for now, I'll start with a bit of housekeeping. The webinar is being delivered in English with simultaneous French and Spanish interpretation. Just click on the interpretation icon at the bottom of your screen to access this service. The session will be recorded in all 3 languages and will be available on the ENN website and the MAMI Global Network webpage. It is wonderful to see so many of you joining us, but unfortunately too many for individual introductions. And as I said, do introduce yourselves in the chat box. As we go along, please post any questions in the Q&A section and not in the chat box function, as this helps us keep on track. We'll both answer questions directly and bring a selection to the panelists to answer live in the discussion session. Speaking of which, I'd now like to invite the presenters and panelists to switch on their videos so that we can meet them in person. So we have Dr. Praveen, we've got Gronya, we've got Curly, we've got Marco, we've got Kelsey, and we should hopefully have Sinuel joining us. There's a bit of a problem with this connection we're hoping to resolve. And indeed, in his absence, I'll start off with Professor Sinuel Gurmaz. He's here very much in spirit, and hopefully we'll be hearing his voice shortly. He is a pediatrician with more than 20 years of experience as a clinician, researcher, and medical educator in Ethiopia, a senior researcher at Jimmy University and at Harvard T.H. Chan School of Public Health. He is a lead researcher on the MAMI Rise Research Partnership in Ethiopia, which we'll hear more on later. Dr. Praveen Kumar is a pediatrician working as Professor of Pediatrics in Lady Hardinge Medical College and associated Kalawati Saran Children's Hospital in New Delhi, India. He is the lead coordinator of the National Centre of Excellence for Severe Acute Malnutrition Management and a member of the MAMI Global Network Steering Committee. Gráinne Maloney is the Senior Advisor for Early Childhood Nutrition based in UNICEF, and Curly de Paulnay is a medical doctor with a background in pediatrics and technical officer in nutrition at the World Health Organization. Both Gráinne and Curly are also members of the MAMI Global Network Steering Committee. Marco Carac is a clinical associate professor and program director for the Nutrition for Global Health Masters program at the London School of Hygiene and Tropical Medicine. He is co-chair of the MAMI Global Network and lead researcher on the MAMI Rise Research Partnership in Ethiopia. And Kelsey Gray is a nutritionist at ENN and is the MAMI Global Network coordinator. So that's our team, and we'll be hearing more from them at various stages through the session. So on to our agenda today. We'll begin with a brief introduction from myself and Marco to help set the scene, followed by half an hour of country conversations with Professor Sinuel and Dr. Praveen. We'll then move straight into a 20-minute panel session where they'll both be joined by Marco, Gráinne and Curly. And we'll begin with a few reflections from Curly on evidence-to policy from WHO's perspective. We'll conclude with a presentation from Gráinne at UNICEF to describe UNICEF's strategic plans and commitments on MAMI and share some of our ideas for MAMI-sensitive commitments we'd like to see coming out of the N4G summit. We've got a busy program ahead, and so without further ado, let's get going. And I'm going to begin with a bit of context about who we are and why we're here. The MAMI Global Network is an active community of practitioners, researchers, and policymakers from around the world working together to improve policy, evidence, and practice for management of small and nutritionally at-risk infants under 6 months and their motherwards. In other words, MAMI. This group is coordinated by ENN, co-chaired by ENN and LSHTM, and steered by committee with UNICEF, WHO, NGO, academic, and country representatives. Our vision is that every small and nutritionally at-risk infant under 6 months and their mother is supported to survive and thrive, which I'm sure dovetails nicely with both the personal and professional visions of every one of you here today. We are strongly committed to supporting country priorities and actions, which is why we have convened this side event and placed Ethiopia and India's stories at the heart of our conversations. Why does MAMI matter? A high proportion of infants under 6 months in the world are identified as malnourished. About 1/5 are wasted and or stunted, underweight, and are often low birth weight. Babies may be born wasted or stunted, and incidence peaks in the first 6 months of life. These babies are at higher risk of death, sickness, and of poor growth, development, and health in both the immediate and long term. First and foremost, we want these millions of babies to survive, but not dead, which effectively is what survival means, is not really good nor ambitious enough. We want them to grow well, but again, that is not an end in itself. They need to be healthy to reach their full potential, and their health is a universal wealth. Malnutrition in an infant is also a sobering sign of our neglect of maternal nutrition and health. The well-being of an infant under 6 months is intimately linked to the health and nutrition of his or her mother, yet the needs of the mother are often not considered. We look only at the infant and fail to look into the eyes and the lives of the mother holding them. We need to right this wrong, both in the interest of infant outcomes and to support the well-being of women in their own right. MAMI offers us an entry point to begin to do so. Preventing and addressing early life growth failure and maternal nutrition and health has been a neglected area within the first 1,000 days that has impeded progress on global targets. Significant improvements in the outcomes of these at-risk infants and mothers are essential to achieve Sustainable Development Goals 2 and 3 especially. These are the infants and mothers who are furthest behind and have so much to lose, but if we act, so much to gain. The revolution we saw for the community-based management of wasting for children over 6 months needs now to happen for infants under 6 months, with integration within healthcare a guiding principle from the very start. MAMI must be an integral part of universal health coverage to both prevent and treat malnutrition. It's not all doom and gloom. Over the past 10 years, we have seen good progress. There is much greater recognition of the high burden of care in infants under 6 months and their mothers, with some critical international and national policy developments and programme innovation, about which we'll hear more of later. And to help translate policy commitments into practical action, the MAMI Global Network developed the MAMI Care Pathway Package, an integrated care model designed to embed within health systems and services to support continuity of care for at-risk infants and their mothers. It looks to leverage what already exists, such as integrated management of childhood illness, and provides a framework and guidance to bridge nutrition and health disciplines. Marco will elaborate a little further on this approach in the next session. But to impact on SDG targets, we need MAMI at scale. To get there, we need to build critical evidence on scalable, sustainable pathways of care that are integrated within and strengthen existing national and subnational systems and services. We must also figure out how best to manage care where health systems and services are disrupted, limited, or absent in fragile settings and in crisis. One type will not fit all. We need evidence from different contexts on if the MAMI care approach works, what shape it takes, how it works, what it takes in terms of cost, health system strengthening, and health worker capacity, and what it means for communities, families, fathers, and mothers. We are looking to countries for leadership and learning to help build this evidence and show how we need to do it. In this session today, we will explore how we can join forces in this effort through partnership and transformative collective action, and what commitments are needed by us and others to help make this happen. I will now hand over to Marco to say a few more words.
Great, thank you very much. Can I just share my screen, please? Thank you very much, Marie. Thank you to all our participants who have joined, and really look forward to sharing this with you. So I'm going to share a few words about the MAMI Care Pathway. So give an overview of what the MAMI Care Pathway is, what it's about, but really using that as a means to reflect on why effective partnerships matter. And I really want to flag, to begin with, the partnerships with our collaborators over many years on this work. And as Marie did, special thanks to our funders, Irish Aid, Eleanor Crook Foundation, who make it all possible. So the first point is three key messages I want to get across. The first is that infant nutrition or malnutrition is a complex issue. To tackle it, we need better partnerships and co-creation of solution, and this is really vital for GRIPS, for getting research into policy and practice at scale. And the MAMI Care Pathway is an example of that partnership. It's about building bridges to help small infants survive and thrive. So Marie already raised some of the issues about why. So why does this matter? For infants who are small and nutritionally at risk, there are short-term risks, mortality, morbidity, but really importantly, there are medium-term risks. So they don't achieve their optimal developmental potential. That later impacts on educational achievement, on their life chances, and even increasing evidence that early life undernutrition also impacts on long-term health, particularly on non-communicable disease, mental health. And I think we're all familiar with the first 1,000 days window of opportunity. But within that, there's a particularly important gap in the first 6 months of life. So there are these critical early life opportunities, but really life cycle benefits and even intergenerational benefits if we get it right. So there's really everything to gain. And how do we do that? Well, one of the key principles underlying MAMI is that we want every infant and mother to be assessed and supported at every community and health service contact. So this is the early life course, and we know there have been great advancements in antenatal care services, great advances in maternal care, but it's using that as a contact point to support the mother, that critical in utero growth stage. There are contact points at birth. There are contact points in immunization programs. So the vast majority of settings work really, really well. Are they used optimally to consider nutritional status, consider other things? So we've got these 3 contacts, 6, 10, 14 weeks. We've also got other contacts when infants attend the health center for a minor illness, a cough, a fever, short episode of diarrhea. So all of those are existing contact points which we can use, which we can leverage to identify and to support where needed. And of course, complementing all of those, many, many community-based contacts that we can take advantage of. This one is a deliberately complex slide because it wants to, so what I want to do here is just highlight the health system is complex and we need to fit within the complex system. So we need to consider tertiary level care, we need to consider secondary care, community care. These are our critical periods that we're dealing with, the early postnatal and later period of infancy, which we want to identify and manage. So it's not about the detail here, it's just to emphasize that the system is complex and we need to bridge across different parts of the system. And in the longer term, also really make a lot closer collaborations with maternal health, antenatal care. So how do we do that? If you haven't read it already, this is a great piece by Dr. Seher Abimbola and Professor Madhu Pai. So two professors talking about power asymmetries in global health. And they have the analogy of the elephant, the story of the elephant, which I think lots of us have heard about. And about the problem, if you have blind people who are feeling different parts of the elephant to understand what it's like, because they're only feeling part of the overall picture, it's difficult to understand the whole. And so we have very small infants, but we have a very large problem, and we need to understand the totality of the problem. So if we just see the nutrition, if we just see the tail, yes, that's important, but it's only part of it. If we just see the ear, domestic, social issues, that's really important, but it's only part of it. Maternal health, vitally important, but that's only part. Infant health, vitally important, but that's only part. And also bridging different perspectives, research perspectives, policy perspectives. So we need to take off the blindfolds. And above all, we need to communicate with each other. We need to work not in isolation, like the characters in this photo, but together and communicate and share our stories, share our narratives of different parts to put them together to a coherent whole. The way to do that is via effective partnerships. So I don't have time to go into details, but the link is here and it's a fantastic document. And just a reminder of 10 key attributes of effective partnering. Firstly, a clear mutual understanding of the word partnership. Agreement to shared vision and common purpose. Thirdly, allowing for and accounting for individual organizational interests. Co-creating and designing decisions and solutions together. So committing to sharing the risks as well as benefits. Again, we do need to take the risks to get big rewards. Contributing resources, both direct and indirect. Shared decision-making and leadership. Committing to mutual and horizontal accountability. Working together and really thinking about the process, not just the final outcomes. So how this works in MAMI. So in developing the MAMI care pathway approach, a key part of that is working in partnership. So it's bringing together a large multidisciplinary, multi-country team working in effective partnerships and co-creating. And it's great to see many of you on the call today. And again, big help to those who contributed directly, but also the many over the years who contributed indirectly through coffee conversations, ideas, things that you've written, things that you've shared to the wider idea. It's about bridging interventions, service and perspectives. So it's about nutrition and clinical and social interventions. It's about caring for the infant and the mother, and indeed the wider family. It's about development and emergency humanitarian settings, so bridging those. It's based on previous success. And it's based on the observation that simplicity is good, that speed is good, that integrated care pathways work well, and towards them that the process, planning and participation all really matter. And it's really building on existing nutritional, clinical and other services. So ultimately what we want is better satisfied carers, better treated infants, but also really importantly, better satisfied staff. So looking after our workforce a lot better. And that's clearly beneficial to managers, it's beneficial to programs, it's beneficial to national governments, to international policymakers and funders. So it's about making it a win-win-win. And how the pathway looks. So it's two basic stages. So we have a stage of screening and a stage of treatment. So most infants come in and we want every infant at any health service contact point to undergo a rapid screening. So a rapid assessment of their anthropometry and a few questions to mum. At this stage, the vast majority will be low risk, so they don't need any specific care. They can just go back to routine healthcare and counselling. There'll be a small number, and our data suggests some 10 to 20%, depending on context, who need a more in-depth assessment. So they're identified to be small, potentially at risk. So they have in-depth, detailed assessment. Some of those are clinically unwell, they're sick, so they need to go into initial hospital care. But the vast majority can go directly to outpatient care, so to have outpatient support. And then they follow up, they keep going in that outpatient support until reaching 6 months of age, at which stage we hope that the vast majority will be better and recovered, but they can be referred for further care. And really important to say that building evidence for this is a team effort. So again, just really want to thank our wonderful partners at GIMA, at GOAL, at ENN. So we're working together in partnership, but also really critically having visionary funders and supporters. So rather than be a very short project, which is over and done and doesn't really learn a lot, it's about the investment, and again, really, really grateful to the Ellen Crook Foundation for investing in the formative work, in the time planning, designing, co-creating. And this is what the end of the workshop looks like. Everybody's happy, everybody's satisfied. But in that, there's been lots of hard work, lots of discussion, lots of things written. But what we're also doing, and again, why this formative phase really matters, we're also consulting healthcare workers who will actually be doing the work in practice in the future. And we're also consulting communities. So this is a beautiful Ethiopian countryside, and you can see just the scattered, isolated communities. And we don't just want to hear the ones who are nearest to us and loudest. We also want to hear those who really need the care and those who are least accessible. So in summary, we want MAMI to be not just about the individual parts of the elephant, not just about the nutrition, even though the nutrition is really important. We want it to be about nutrition and health. We want it to be about mental health as well, considering the importance of that. We want to add the consideration of social care, social services, and child development. And within that, all of those, of course, nested in the wider context, the wider environment, family, social, national, and global, and together helping not only the children thrive and fulfill their top potential in the long term, but also helping the programs thrive and helping individuals, communities, and nations thrive. Thank you very much. And for more, do check our websites. Thank you.
Thank you, Marco. We've been working together for about 12 years on MAMI, I think now, and every time I hear you talk, you bring fresh thinking and ideas to the room. So thank you so much. But we are but the warm-up act. And without further ado, I am now delighted to start our country conversations. And we're actually going to begin with Dr. Praveen, who will be in conversation with Kirali from WHO. At the moment, Dr. Sinuel, Professor Sinuel has not been able to join us because of a problem with connection. So we are hoping we will have him follow afterwards. If not, we have an audio recording of some questions that we posed to him earlier on. But please do listen to the questions that Kirali is posing to Dr. Praveen, as the same questions we posed to Sinuel. So over to you, Kirali and Dr. Praveen.
Thank you, Marie, and thank you, Dr. Praveen, for being here today and giving us the country perspective from India. So let me start with my first question for you, and I'd like to go into sort of 3 parts of this. So the first one I want to talk about is what is the situation regarding small and nutritionally risk infants under 6 months and their mothers in India? Tell us, is it a problem? The next part I want to ask you about is are there government priorities to address it? And then the final part I'd like you to speak to is whether or not there are any policy and services gaps or weaknesses.
Okay, so thank you very much, Primi, for this question. Yeah, so this small and nutritionally at-risk infants, this is a public health problem for India. Why so? Because last surveys, national level surveys, And few published studies, they have documented that we have very high prevalence of wasting in infants under 6 months. And in India, almost 1/3 of newborns, they are small at the time of birth. So almost 28 to 29%. And then we have very high severe wasting, and we also observe a different pattern of wasting if you compare with the other countries. Like in India, you have very high prevalence, and gradually it is settling during infancy. While in other countries, if you see the profile of wasting, then they usually start after 6 to 9 months. So that difference also we have, and that's the reason it's so important for India as a public health problem. Similarly, the maternal nutrition, also the last national level surveys, they have documented that we have very high prevalence of maternal malnutrition also. So that's the reason I will say this is a public health problem for India. Regarding your second question, is it a government priority to address? Yeah, I feel this is a government priority. And why I'm saying this, because last few years, last 10, 15 years, the government is working continuously, and the country has taken several steps for improving care of these low birth weight, high risk infants. We do have no special care newborn units known as SNCUs in almost all districts, catering almost 1 million average population. And where these high risk, low birth weight babies, sick newborns, they get admitted. And then also the country level, we have several community level program platforms like home-based newborn care program, where our community health worker, they visit all these high risk infants. They usually have home visits. Although they are, so far they were mainly targeting and they were looking for survival. So they were looking for signs of sickness. And whole this MAMI, some component is already in practice. But same time, we have some gaps which I will highlight. So what are these? Although we do have programs where community health worker, they are supposed to provide at least 4 antenatal visits to all the pregnant women. They will advise them regarding diet and all. And after that, through HBNC, these community health workers, they visit home. They usually look for any sickness in newborn infants. And then we have a new program launched, which is called HBYC. So that is 3 months, 6 months, these are the additional visits. Although they are supposed to take their weight, record weight, but this component, I feel, there are some gaps. Although they are recording, but that interpretation, actions based on this growth monitoring, that component is weak, and we need some strengthening so that they are able to identify early growth failure, and they are able to take or link and do whatever is needed for that infant. The second component is regarding the maternal health and nutrition. So largely we do have all these antenatal checkups, and we also have national level program on 9th every day, all the pregnant women, we even public-private partnership is there. But then so far, largely these services are directed towards identifying medical problems, like identifying pregnancy-induced hypertension, diabetes, anemia, to some extent identifying intrauterine growth retardation. But so far, we do not have any program for looking for maternal mental health problem. Particularly, I will be talking about community level. They do not have enough skill to identify, neither they are able to. And at community level, we do not have some linkages. If they identify what they will do, where they will refer. So these are the gaps which we have. And definitely this is required, and that is what I will take. Okay. Thank you.
Sorry, Curly, you're on mute, Curly.
So sorry, so sorry. I was just saying thank you for that, and I'm always reminded by the huge numbers when we talk about anything in India. It is really, you know, there are huge numbers involved. So my next question is whether or not you can give us some examples of in-country initiatives to generate this evidence to inform policy change for India.
Right. So thank you for asking this question. I think we have already organized 2 national level consultations. This was done in 2018 and 19. And we reached consensus. We realized this is a problem for India. We reached consensus for defining at-risk infants and mothers based on MAMI care pathway, which we have. And these are also published reports now available in public domain. We have also developed, piloted, and published feasibility and experiences of algorithmic approach for identification of at-risk mothers of malnourished children at our center. But at the same time, India is a large country with no very huge population. And only facility level, no interventions are not going to work for India. The extent of the problem which we have. So we need to demonstrate the feasibility of implementing these interventions, for at-risk, these nutritionally risk infants and their mother through existing government community-based programs, which we have like village health, sanitation, and nutrition days, where they come and there are contacts. We have immunization contacts. We have HBNC and HBYC. I talked about this. So we need to better utilize these government platforms which are existing, which is there in place, but we need to train them, these pathways, and also interpretation, how to identify if there is a poor weight gain, what they should do. If there is a child with moderate nutrition risk, what they can manage at community, when they have to refer that infant to the health facility. And for background, most of our health workers, even community health workers, they were trained in IMNCI also. We have a package IMNCI for health worker also. And which country is at this point of time is updating, and very soon we will have this training also for health workers. So we already have this background. We also need to demonstrate the extent of mental health problem which is contributing, which we do not have at this point of time, and we need to identify platforms and services for tackling this problem. So almost 8 to 10 states out of the number of states, 38 states we have, they have shown interest and they have included in their yearly plan to implement this adapted MAMI care pathway, which we already have consensus in their respective states. And we are hopeful that these experiences from these pilots, which we will have locally, will lead changes in policy of bringing that thriving component which we have in MAMI, along with the survival, which we are focusing for last many years. So this thriving component probably will be added to this with these pilots coming. Thank you.
Thank you. So Marco was just talking to us earlier about the importance of partnerships in co-creating this evidence. What are your thoughts and what have your been experiences of this in India?
So I fully agree, the partnerships are needed and collaborations. Without that, we can't have the desired. India is a vast country. So in the last few years, National Center of Excellence, which we have in our hospital, we also have developed a network of a state and regional center of excellence for SAM management, which is severely acute malnourished children management, in 13 states. We have conducted series of consultative meetings and also sensitized national and state level officials about the problem, about these pathways, algorithmic approach for identifying, and importance of early identification and management of at-risk infant and their mother. We have realized that although we have improved survival, but then we also have to continue, we have to take care of their nutrition so that once they are discharged from these special care newborn units, we are able to provide them appropriate care which is needed. So during the last World Breastfeeding Week, and also during recently organized, we had a national consultation. Different states presented the progress outcome towards adaptation of MAMI care pathway in their respective context. And we also had global Marie C participated in that meeting, and we highlighted this problem at country level. Then we are also planning to start MAMI India chapter soon, which will work closely with Global MAMI Network. And we hope with this, we will be able to have better care, and we will improve the quality of care to these infants. Thank you.
So my final question is what commitments do you need from national and international stakeholders to ensure this evidence truly informs policy and decision-making in India?
Yeah, so what I feel, we have now enabling environment for improving care of high-risk infants, because in last few years, the survival has increased. And now at national level and all the states, they have realized that only along with survival, that their nutritional care is also important. And at this point of time also, you must be aware, every year India is celebrating National Newborn Week. We are midway between this 15th to 21st is National Newborn Week, which we are celebrating. And this is primarily for improving care and quality of care to these newborns. So what we are talking also, this is part of improving care to these newborns. So due to high prevalence of wasting among infants less than 6 months, policymakers and program implementers, they have recognized the importance of community-based management of infants with early growth failure. And then we already have existing government community platform which we can use for providing services. But then we need some pilots to show them this is working, this is feasible, because whether these community health workers, they will be able to provide, they will be able to know whatever is mentioned, they are able to identify, that will be needed. And then we do not know at this point of time, we will have to really see whether mental health problems there will be able to identify. And then the problem which, the barrier which we feel at facility level is that most of time the infants are taken care by Department of Pediatrics. The mothers, they will be going to obstetrics gynae. We do not have a common platform where we can take care of both mothers and infants. So only one which potentially, but that is not available in all the hospital or health facility. That is infant and young child feeding counseling centers. We do have in certain hospitals, but I think we need more common platform where we can assess both mother and infant. In health facility, if we identify some mother with some medical problem, we will need to send them link with Department of Medicine, Department of Psychiatry. So all these are the barriers, because most of time we have different departments, and many times it's really difficult. So these are the barriers which I foresee for implementing this program.
Thank you so much, Dr. Praveen. We'll pass back to Marie now. Thank you so much.
Thanks a lot. Thanks.
Thank you so much. And I know we could continue this conversation for hours, but time is not our friend. And so we'll transition over to a conversation with Professor Sinuel. Unfortunately, our connection is still problematic, so he hasn't been able to join us live, but we fortunately posed these questions to him a little earlier this week. And so he's recorded an audio of his reflections and insights, just like as we have discussed with Dr. Praveen. So we're going to play this soundtrack, as it were, from Sinuel, just reflecting his thoughts. Just as a reminder, the first question we posed was really about the situation of small and nutritionally at-risk infants. We then asked about the type of evidence needed for decision-making. What was the importance of co-creation and partnerships, enablers and barriers along the way to developing policy and services? And then what commitments does he think is needed from national and international stakeholders. So over to you, Annabelle, just to share the audio. Thank you.
Thank you, Marie. Hopefully you should hear the audio shortly.
Thank you, Mary, for this question. With regard to the situation or the overall situation of nutritionally at-risk infants in Ethiopia, Ethiopia is one of the most populous countries in Africa with an estimated 110 million population. We have a very high fertility rate, and the low birth weight babies account to 16% of live births. And infant mortality and neonatal mortality are, I think, one of the highest in Africa, with infant mortality around 43 per 100,000 live births, and neonatal mortality with 30 per 1,000. This is based on data from EDHS 2019. We have also a high rate of stunting and wasting. In terms of young infants or infants less than 6 months who are nutritionally at risk, we don't have exact figures, but in some places they account up to 10% of admissions to NRUs. And from a data that I have obtained from the ministry, between January to September 2021, there were reported close to 400,000 cases of severe acute malnutrition or children with severe acute malnutrition, of which close to 2,200 were under 6 months. That may be a small figure, but the data could have some problems because some places, because of some challenge, may not be sending reports fully. And the government at the moment is giving due attention to all these nutritional problems. And I think it's one of the top government priorities, particularly by the Minister of Health and other key stakeholders like Minister of Agriculture and other partners. Recently, Ethiopia has ratified its food and nutrition policy, as well as part of that process has also developed its food and nutrition strategy. And it is estimated to cost around 100 billion per over the next 10 years. The other plan, there is also a plan to avail treatment for nutritionally at-risk infants who are less than 6 months at all levels of the healthcare system in the next 10 years. So this shows the magnitude as well as the some of the initiatives by the government and the focus it's paying to the problem with regard to nutritionally at-risk infants. Thank you. Thanks again. I mean, in terms of evidence that helps policy development or change, I think we need evidence, particularly to improve the current diagnostic criteria for under 6 months infants, as well as also the treatment approach. Currently, our national protocol uses or recommends to use weight for height, weight for length, and weight loss as diagnostic criteria. And then if an infant is found to be malnourished using these criteria, they should be referred to a higher level treatment where they can be admitted and receive inpatient treatment. So we don't have a provision for outpatient treatment. And that's because of the limitations in terms of the data. But this approach have got their own limitations, technical as well as programmatic limitations. For example, taking length is a very relatively difficult and sensitive parameter or procedure. And also admitting these infants with their mothers in a facility could expose them to nosocomial infections, increase the cost of treatment, and it will be definitely an inconvenience for the family. So at the moment, what we really need is a valid and more simplified diagnostic and treatment approach. And for that, there are promising collaborations that will lead to generating evidence. For example, Jimma University, London School of Hygiene and Tropical Medicine, and Goal International are collaborating to implement an RCT to test the MAMI care pathway package. And moreover, there is a long-standing work in refugee camps in Gambela by Goal to evaluate the diagnostic approach and improve the treatment approach. So these kinds of evidence will definitely help in the government to make decisions and policies with regard to the care of these vulnerable groups. And there are also other institutions and experts within the country that support the evidence generation process. And the ministry is closely working with all these partners. Thank you. The idea or the approach of co-creation is, in my view, is an evolving and a novel approach. And it's really important to bring researchers who are traditionally, working in silo within their institution, within their academic environment, and programmers who are struggling with the day-to-day evidence, making decisions, implementing programs with available, evidences, but not fully integrating with those who are producing the evidence. So I think bringing these two entities together is really important. One, to have a more practical research, as well as also developing priorities jointly, and also developing and producing quality evidence, and more importantly, to increase the impact of the research evidence that's being generated. So I think it's really important to have these two elements work together. So with this regard, there are promising developments in Ethiopia. For example, the Ministry of Health is, particularly the Maternal and Child Health Directorate, has got a structure called Research Advisory Council. It has been established 6-7 years back. So one of the main purpose and reason for this structure is to facilitate the delivery, as well as also the translation of evidence to the program people, and then also encourage the academics to work closely and provide technical support during design of policy, and also increase their influence on policy making and program implementation. So we've seen a lot of productive outputs from this. And we can mention that, for example, the one I mentioned about the National Food and Nutrition Policy and Strategies, this was jointly done by experts, local experts drawn from partners as well as academic institutions in collaboration with the Ministry of Health. So this is one example of how this collaboration can create really a very efficient and fruitful work. Thank you. In Ethiopia, we have several enabling factors or conditions that increase the opportunity for comprehensive care for small infants, small and child-at-risk infants and their mothers. For example, there is an increased access to primary health care unit over the last 10-20 years, with most villages having at least one health post, which is the primary health care unit. That's the lowest level. And then it's most of them are staffed with health extension workers who are trained for at least 1 year and provide preventive services. And there is also an increased institutional delivery rates, close to 60%, 50 to 60% of the mothers are delivering in health facilities, and there is the antenatal care follow-up is also increasing, and the postnatal care coverage is also increasing. We have really strong vaccination program. We have also uniquely what we call the community networks like Women Development Army, which are supporting structures for the health extension program in terms of mobilizing mothers, in terms of passing health information, and then also connecting the community to the health system. So these all opportunities could be used to increase their services, to provide services for nutritionally at risk infants and then their mothers. However, there are also certain challenges that can hinder these services. For example, there are emergency situations, either because of political situation or natural disasters like drought or flood. And in these situations, the number of mothers affected and their babies who are vulnerable will definitely increase because of service disruption and lack of the basic infrastructure, and because of the emergency situation. And there is also an observed tendency of mothers to reduce breastfeeding or to stop breastfeeding. In some places, for example, mothers assume that they will get more rations like milk and food items if their babies are not breastfeeding, because they think that will increase their chance of getting more family ration. And then in other places as well, there is a cultural barrier for mothers to breastfeed in upper places. So when they are displaced from their home and then living in refugee situations or refugee camps, it will be difficult for them to breastfeed their babies in the presence of individuals who are outside of their family members. So in these situations, it will be very difficult to give the required services, as well as also to encourage mothers to care for their babies in the usual pattern. So these situations and others, like lack of resources, limitation in logistics and the supply management and so on, will definitely affect the service that could be provided for vulnerable mothers and their infants. In terms of the support that the government should get from national as well as international stakeholders, I think one of the most important is having quality evidence that will help refine or develop new policy approach or increase the effectiveness and efficiency of the services. The other thing is this coordination, coordinating the nutrition services with the government plan and approach. Ethiopia is a very big country and has got difficult topographies, and infrastructure is not well developed. So there is a lot of need to have a coordinated effort in terms of reaching those who are vulnerable. And also there is a critical shortage of drugs, supplies. So I think this is an important area where the government can benefit by closely working with stakeholders. I know Ethiopia is benefiting from support from international community, but there is, the problem is huge. The nutrition problem is huge, and with increasing, fast growing population, and with different difficult situations, arising from time to time, I think we need more and continued support to address all these challenges, not only in terms of resource, but also, as I said, in terms of technical support. Ethiopia has several local institutions, academic institutions, and these have to be also encouraged to work with the government in terms of supporting the different initiatives. They can, the universities are spread across the country, and they can link with their local community to provide the technical support, as well as also, in terms of mobilizing resources and supporting the different activities. The international community should also continue its usual support. And probably now we're in a difficult time, was because of COVID, as well as also some political situations. I think this is the time for international stakeholders to pay more attention and to be more sympathetic and provide the necessary support. Thank you.
Well, thank you, Dr. Praveen and Professor Sinuel from afar for some wonderful insights that I am sure have whet our appetites to hear and share more, and which we can now do in our panel discussion. So I now invite Kiralee, Grania, Marco, Kelsey, and Dr. Praveen to unmute, switch on your videos and join us. To you all out there, please do pop your questions in the Q&A. I think many have been coming in. Some have been answered directly, but we'll also have some that we will pose to the panelists. And to help us focus in on the theme of the side event, growing partnerships to co-create evidence on MAMI to transform care, we'll kick off with a few words from Kiralee on evidence to decision-making and policy development from WHO's perspective. So over to you, Kiralee.
Thanks, Marie. And thank you for inviting WHO to speak at this side event. So I've been involved with MAMI for the last 5 years, so I don't quite have the long and illustrious history that Marie and Marco have, but I've been involved on the outside and now on the inside.
Yeah, this is for me.
I'm just going to talk quickly, Dr. Praveen. So as I was saying, so I've been involved with MAMI on the outside and now on the inside of WHO. And I think I can confidently say that WHO have strongly heard that loud knock on the door that the MAMI Global Network has consistently maintained. I do think a lot of this has to do with the long-term commitment from individuals in WHO like Nigel Rollins, who has really been instrumental in listening to and being part of many MAMI meetings and initiatives. And also Zita Weiss-Brinso, who has been on the steering committee for MAMI, but has kindly let me take over her spot, knowing what a MAMI mega fan I am. So if I relate this to some ongoing guideline work in WHO, for example, for the wasting guidelines that we're working on, we have PICO questions, which are used to guide how the evidence is mined in systematic reviews, and then lead to the development of guideline recommendations. 6 out of the 16 quantitative PICO questions we have are focused specifically on infants less than 6 months and on their mothers. That's almost half. One of these PICO questions has 4 subsections which cover the hugely vital questions of what criteria will trigger initiation of these infants and their mothers to treatment, what will trigger referral to inpatient and then referral back to the community, and finally for discharge. And even alongside the wasting guidelines, there's another piece of work, again being led by Nigel Rollins and Rajiv Bal at WHO on risk stratification, trying to look at aggregated and patient-level metadata to really identify those infants most at risk of mortality and serious morbidity. A further 4 PICO questions we have cover both infants and children older than 6 months for specific nutritional and clinical interventions, and topics that perhaps in the past infants would have been left out of. This is alongside the guideline for preterm and low birth weight infants, which are also currently underway in WHO, and will also hopefully add some vital pieces of the puzzle of how to best look after these infants. So as the evidence is scoured through these systematic reviews, spoiler alert, we are likely to find gaps in the evidence. And then if and when we see these evidence gaps related to infants less than 6 months and their mothers, we will make sure that these are collated and incorporated into an updated research agenda for wasting. The new UNICEF WHO partnership has a special work stream on this research, both from the operational and the normative research perspective. And I can tell you that I will make sure that infants and their mums are there. Now, along with the infallible logic of treating a mother and an infant as one, is the infallible logic that this should be an essential component of universal health coverage. As Marco said to us many times, this is not just a nutrition issue, it's a maternal and child health issue. I think that's also reflected in how both the nutrition department and the maternal and child health departments in WHO work on this topic so closely. And we must not forget the small world for our infants and our mothers in fragile and conflict-affected settings, and the importance of still keeping the MAMI lens on our policies and services, but adapting them to field realities. So we will continue in WHO to keep the MAMI lens on all work we do on small and nutritionally at-risk infants and their mothers. We hope to make great progress in this topic in the near future, and we hope at the heart of this is the evidence which has been co-created by implicated organisations and institutions, and above all, by the countries and the communities trying to directly look after these infants and their mothers. Thanks.
Thank you very much, Curly. And indeed, we hosted a couple of days ago a webinar with WHO on this wasting guideline process, and that will be available on the ANN website too, and covers a lot of territory on infants under 6 months, like you say. So I'm now keen to hear some of the questions coming from all of you. So Kelsey, what have we got?
Thanks, Marie. I think the first question, just to sort of set the scene, could you answer, in the MAMI approach, what are the key treatments for infants under 6 months?
That's a great question. Maybe I'll kick off and then allow others to come in. So the two key treatments are specific treatments. So if a mother comes in and if the underlying issue is, for example, mastitis or a breastfeeding problem, then you focus in on that. It could be the infant has an underlying infection, so then you focus on that. It could be something like maternal mental health, then you focus on that. So the MAMI treatment, MAMI care pathway is all about identifying what's the main underlying issue in this particular infant-mother pair. So that's one part, the specific treatment. There are also really important general treatments. And these are cross-cutting issues which are important to everybody. And they include, number one, support with maternal mental health, and that's principally through relaxation. So Jonathan Wells, Mary Futrell and colleagues have done some really, really interesting and important work. A simple relaxation intervention both makes people feel better, but also increases breast milk supply, decreases cortisol in the milk, so and increases infant growth. So that's a really growing field. So the general thing is mental health via relaxation and just by engaging with a mother. Secondly, addressing sleep and crying issues. And again, that's because anybody who's had a young baby, I mean, I've got 3 children and I found it completely exhausting. But yeah, it was actually my amazing wife who did all of the hard work. So it was exhausting for me. So I can only imagine what it's like when you don't have that support. So addressing sleep and crying, addressing explicitly family and social support, so having the conversation with a mother about what support she's getting. Is she getting support? Is she getting conflicting messages from the grandmother or the father? So, and how can we work forward and improve that? Then we've got kangaroo care and early childhood development. And then finally, towards the end of treatment, there's a brief discussion about family planning and then complementary feeding. And so it's important to say that the care pathway involves initial weekly visits just while the infant is high risk, but then very quickly they de-escalate. So some infants may need weekly visits for a couple of weeks, others may need weekly and then can go down to fortnightly and then monthly. So very light touch, but it's about being engaged and it's about following up everybody till they're age 6 months. So that at 6 months, there's a very specific follow-on service and there's an action that can be taken if an infant is found to be still small. So principally referral to CMAM programs, but also referral to clinical programs. And so in summary, and again, check the care pathway, it's specific treatments and then those general treatments, which are of benefit to everybody. Thank you.
Thank you, Marco. Kelsey, what more have we got?
Great. It would be great if you could just speak a bit more to, so what steps are being taken to integrate the MAMI approach into existing country guidelines on the management of malnutrition?
Great. I think maybe Dr. Praveen, would you like to give your insights on that? So the MAMI care pathway might be integrated within, say, national or subnational guidelines?
Right. So as I discussed, we already had 2 consultation meeting, and the changes, the certain components are already integrated, like wait for age now, for less than 6 months is being used for identifying at risk all the infants. So that is already integrated. Also the updated IMNCI, we will have these identifying at risk infants who are not gaining weight. That also component is already being integrated. So there are certain component which is already being already integrated, and certain component which we need more work and more, we will have to see feasibility that we are trying to do in probably that we will be able to do by next year. Thank you.
Thank you, Dr. Praveen. And just maybe it just prompts me to ask you, and reflecting on that question, in terms of the pathway of influence, you talked earlier about the pilots that are happening and at various states. And what is the mechanism or route in terms of their influence? Will they influence state guidance or federal level, or how does that work within India?
Right. So we started this piloting in 10 states, through the centers which we have for children with severe acute malnutrition. And all these centers, we started using wait for age, and we started seeing the feasibility of using MAMI care pathway principle for both mothers and infants. So that is already done. The feasibility has been documented and is already published also. And the next, which we have to demonstrate at community level after integrating whether this is feasible or not, that we will be doing.
Thank you, Dr. Praveen. And we are missing Sinuel's voice on this panel today. I'm sure he would have a lot of insight, but just to say a few words, I guess, around the partnership that the LSHTM and ENN, Goal and Jimmy University have, and part of the significant formative phase and the co-creation and partnership is very close conversation with Ministry of Health and identifying what are the policy priorities that are needed in helping to design the evidence. Marco, I think, could say a few more words on that.
Yeah, so just to add, that in terms of kind of WHO and UNICEF, like Carolee said, that they've both been really keen and hugely supportive, and been really key to, Nigel, Aziz, and many others in WHO have been really key to moving it forward within WHO to be one of the 4 key guideline questions. And similarly, Grania, great to have you on the call now, because you've done a huge amount within UNICEF HQ, and are doing a lot, and just those really critical steps about noting it in strategies and guidelines. Clearly there's lots more work that needs to be done before it's just adopted, but those steps are taken. And also, looking at others like Professor Farouk in Ethiopia, it's about those key visionaries in working at national level who've really made a difference, who've found out about it, and who are then making the difference about getting it in. But one of the big barriers that we found, and I think I typed that in one of the other questions, is that governments and organizations, I think very, very rightly, want to see some more evidence of it at practice and how it actually works in the field. Because it's one thing having the theory and the plausibility, and clearly it's very plausible. There's no reason why it shouldn't work, because they're all these things have been tried and tested and work brilliantly for other populations. It's just they haven't quite been tested for this particular population. So that's why getting that evidence is really vital. And again, great to have some messages along people who are planning work. So do join the MAMI Global Network, share what you're doing, write up that evidence and share it, and not just the clinical and public health evidence, but we also want to see good economic evidence, because we see this not as a cost. It can't be a cost, it's an investment, both for short term, but also for long term development, educational, personal, community, social achievement, and even long-term NCDs. So it's about an investment, but we need to make the case in writing. And thanks to all who are doing that now, and all those who hopefully will do it in future. Thank you.
Thank you, Marco. Kelsey, over to you.
Thanks, Marie. I've had a number of participants have asked the same question. So they're wondering, how is the quality of MAMI programming monitored? And what's the M&E framework?
Yes, so who would like to have a go at that one? I think as Marco had shared in his earlier thing, it's a package and a resource that is then taken at country level and very much looks to leverage what exists. So very much dependent on the monitoring and the evaluation and the data that may or may not be gathered and needs building and strengthening. And I think that's quite a critical gap area often, that we lack the visibility of data and the quality of data. But I think this will vary very much by context and by setting and country. I see Marco's wee hand is up again, so I'll pop him in there, and I'm sure maybe Gronya might want to say a few words about data too. Marco.
Yeah, or actually I'll let Gronya speak first and then I'll come in later. Gronya, if you have comments or Kiralee.
Sure. Thanks so much, Marie. This is a great question, because if we don't have data, the issue isn't visible and we can't monitor progress. So I think within the nutrition community, we have made great progress in recent years on lobbying to get core nutrition indicators into the DHIS2 system, which is really where we want to go. We don't want to be establishing parallel systems, as Marie said. But we do know for infants, there are issues. It's hard to weigh these babies. It's hard to take the length, as mentioned. And it's not necessarily always documented and registered. So we need to do better, because we need to show impact. So this is a priority for all our children under 2 years, but particularly for the infants. How do we get better? How do we find better tools, better scales? And how do we find just a way to show impact and progress? So just to say that context varies, different countries have different indicators, but the idea is that these tools are adapted to context and build off whatever's available. And then when gaps are identified, that we work together on trying to find a way around it. And I also feel the importance of qualitative data often is underestimated, and we need to also look at behaviors and practices, what's happening at community level. So there are some interesting tools also developed at community level that we need to further exploit and accelerate their adaptation. But this is exactly where we need all of you online to help us, help share your tools. I see all these great emails from Marco to say, join the team, get involved, share your tools, share your ideas. How can we do better, both from the quantitative perspective to measure outcomes, but then also let's look at behaviors and practices as well, because that's core to measuring success in this work. Thank you.
Thank you, Gronya, and a really good call for that qualitative, because irrespective of what the outcomes are, we need to know how we got there and what are these mechanisms of action and change, and the interactions between the users and the service providers, which is what we're always missing. And we always focus on the intervention, but it's the context which is critical, and what is the interaction between that context and the intervention, and how it works and doesn't work. So really that is so critical. Marco, perhaps a few words from you.
Yeah, thanks very much. I think just to echo that understanding the process and qualitative indicators, so important. But just also in terms of the M&E framework, that's been developed, but for now it's really echoing what's already done in nutrition. So the key indicators would be percentage who are cured, percentage who have an ongoing problem at 6 months. So that can be either a clinical issue or a nutritional issue, so who need referral. Percentage default, which we clearly want to minimize because we don't know then what's happened. And because these are a very vulnerable group, sadly there will be a proportion who are dead. So it's really the standard nutrition program indicators, and we're also thinking about coverage in long term, but the tools for that are in progress, but they overlap significantly with tools and approaches already available for older children. And I think just the big difference is that the exit is not when they've hit a certain weight threshold or when they're growing at a certain grams per kilo per day, because that's too complex. Everybody exits at 6 months. It's just that some need intensive care for that 6 months. Others need very light touch care, but we want to know how they're doing at 6 months. Thank you.
Brilliant. Well, I'm sorry I'm going to have to draw this discussion to a close. I don't know where the time has gone, but it has. And I hope that this is these questions and answers and insights are just going to be help sort of catalyze many conversations on MAMI wherever you are. I want to take a moment actually just to mention something which Dr. Praveen referred to a MAMI country chapter just in his conversation, because this is sort of an initiative of the MAMI Global Network that we're very excited about. And really our vision is that this is a network at national or subnational level that brings an infant under 6 months or a MAMI lens to in-country initiatives, departments and groups across policy, research and practice. And Sinuel really described, as did Dr. Praveen, how they are actually doing that. And so really, this is not about creating something new. It's that it's actually embedding that lens or just bringing visibility to a forum or an entity or a movement at a country level that already exists or could help or could maybe be kick-started. And the aim is twofold. First, to help harmonise country efforts around these infants and mothers, but secondly, to provide a direct avenue for countries to access, contribute and amplify their voice in global efforts to an official link with the MAMI Global Network. So we're excited to say that we're at the early stages of developing those in India and Ethiopia, and just really leveraging what there exists and just making sure we hear and learn and connect with them. So now, as we're drawn nearly to a close, I'm going to hand over to Grania to outline UNICEF's commitments, opportunities and directions of travel on MAMI, and then to share some of our suggestions on MAMI sensitive commitments we'd like to see coming out of the N4G opportunity in December to get the ball rolling. So over to you, Grania.
Thank you so much. So I'm going to fly through my slides, but just to say that for UNICEF, this is an absolute priority. And many of you will know that at the beginning of 2021, we launched our new 10-year strategy to take us to the SDGs. And the strategy celebrates a lot of progress. We've reduced child stunting by 1/3. We have 55 million fewer stunted children, and we have 80 million more children being breastfed, but there's a huge amount of work. And I think the third point here is particularly important because our data is showing us that at least 2 in 3 children, young children, so this is children under 2, are not being fed the minimum diet they need to grow well. So this is extraordinarily of great concern. And within that group, it's the youngest children that are the most vulnerable. And of course, that includes children under 1 and children under 6 months. So this group of children really add to our burden of wasting globally. And therefore, if we don't intervene early, we will actually set these children up for failure in their growth and their overall development. So our vision for our strategy is a world where all children, adolescents and women realize their right to good nutrition. And our goal is to promote diets, services and practices to support that optimal nutrition growth and development for all women, adolescents and children. And in fact, many of you may notice that we're making explicit reference to women and adolescents, which we may not have done so in the past, but we're making a full commitment to really focus on the life cycle approach to improve nutrition outcomes going forward. So what does this look like in practice? Well, the vision of our, or rather the universal principle of our strategy is that prevention comes first in all contexts, and that's all forms of undernutrition. And if prevention fails, treatment is a must. So you will see, for example, the first 3 objectives are focusing on prevention, and objective 1 focuses on early childhood, early life. In fact, that's my portfolio. And this is where MAMI is explicitly referred to as a major tool in our work. And then, of course, on the treatment side as well in objective 4. In terms of what this actually looks like, UNICEF for Nutrition for Growth, and we're going to talk about Nutrition for Growth commitments in a minute, has made a number of commitments. And one of the commitments we have made is on wasting. And this refers to our new approach to the early identification, prevention, early identification and treatment of child wasting. And we're referring to one specific target that we have, which relates to supporting 30 countries with some of the highest burdens of wasted children across the globe. Now, this does not mean that we will not work in the other countries where we normally work, but we are saying in these 30 countries, that UNICEF will reach at least 100 million children with services for prevention, early detection and treatment, including at least 9 million of those children receiving timely treatment by 2025. So we really want to ramp up our efforts to protect children from malnutrition, but then intervene early and treat them for those who need it. Now, the document, No Time to Waste, which many of you should have by now, it was released back in August. It really highlights the importance of a life cycle approach in prevention, so brings in the mother and the infant child. It specifically identifies age as a risk factor for wasting, highlighting the fact that younger children, they're more vulnerable. So again, bringing in the importance of MAMI. It highlights the importance of these interventions for early identification and interventions through facility and community-based approaches as part of a continuum of care. And again, this is exactly following the same as the MAMI care pathway, looking at one continual support services for our vulnerable children. And it does make explicit reference to the MAMI care pathway as an appropriate strategy. So that's our No Time to Waste approach. But we've also recently released the second document that you see highlighted here, which is integrating early detection and treatment of child wasting into routine primary healthcare services. And this resource also explicitly references the MAMI care pathway as a core resource to achieving that. So if you want to look at what it looks like specifically, and this is our framework for how we address child wasting, you'll see I've highlighted areas that refer to, for example, increased emphasis on children under 2, where we put our services, a coordinated approach again with to integrate services with the emphasis on children under 2. So we're really trying to highlight that risk of younger children getting in early, making sure they can access all the services they need. So take time, if this is of interest to you, to have a look at our document, and you will see references to MAMI, and you will see references to specific vulnerabilities and risk for these younger children, because we do know that if we want to reduce our burden in wasting, we've got to deal with this particular population, and we've got to do it at scale, and be very serious about this. So in summary, all of this to say is that UNICEF is committed to supporting MAMI in our work, and we look forward to partnering with many of you online in generating that evidence that we need to see what works, and then accelerating progress for this particular vulnerable group. And as Kirli said, we're very excited about this new partnership with WHO as part of that journey in generating that evidence. So now I'm going to transition into the next part of my slot, and this is, okay, so we've spoken now of UNICEF commitments. We recognize that there's a huge amount of interest around this particular age group. So what can we do as a community to encourage smart, ambitious commitments for investing in MAMI at N4G? N4G is in 2.5 weeks. The clock is running down, and this side event is to help stimulate that discussion about what agencies and different actors and stakeholders can do to support this agenda. So we've listed about 4 examples of types of commitments that could be appropriate for different stakeholders, for governments, for civil society, for academics, for UN agencies. So I'm going to quickly run through them, but what I would like from all of you is to have a think about, are they something that you in your agency and your role, is that something, a commitment you could make? Do you have suggestions of other commitments that you are making? Please post them in the Q&A or the chat box, and let's make sure we're continuing this discussion in our last few weeks to this extraordinary opportunity of nutrition for growth, and really make sure that we use this opportunity to give these needs and these children an opportunity for large-scale investment. So, for example, ask 1 would be, how do we make the needs of small and nutritionally at-risk infants and mothers visible? And there's a couple of suggestions on how. This goes back to, if we don't have data, if we're not reporting on it, these issues are not visible. How do we make sure we include infants and their nutritional status in our surveys? How do we disaggregate our data? That's the first one. The second one is, we need to really undertake fair and ethical research that addresses national and international evidence gaps. So working with our government partners from the conceptual stage, when we are doing research, bringing core people on board, establishing different partnership criteria and benchmarks, and really understand the process of co-creation and ownership. So the type of research we generate will actually ultimately lead to significant policy change in these countries. The third ask is show and tell us your innovations, experience and action. So how do we actually get this information out there? How do we, as a community of practice, start sharing this information and get a buzz around this subject and get people serious in a large way? So this, for example, would be publishing our research and in preprint and open access journals so that it's accessible to everybody, document and share implementation experiences through obviously field exchange that we're all very familiar with. Get involved in the MAMI Global Network. You saw Marco's call to join the forces. So please do get involved. Lots of the links have been posted on the chat box. And finally, we need to be accountable for our actions and inaction. And how do we do that? The core thing is, again, indicators. We need to make this visible and we need to show progress. And we do that through establishing targets in national and global tracking and accountability mechanisms. Now, I apologize for the speed. We're running out of time, but these slides will be shared and I look forward to your contributions. I'm going to hand back to you, Marie. Over to you.
Ronya, thank you too much. You did that with speed and style and very, very clear. Thank you so much. And really just to reiterate, we don't have all the answers. And indeed, that is why we have convened this side event, galvanizing collective brain power on the asks, the how and the action. So please do examine the commitments you are lobbying for or making for N4G to see if you can add or tweak to sensitize them to MAMI, and look at initiatives you are working on more generally and see how addressing MAMI will actually help you achieve your vision and targets. So to close, and I'm sorry to say we're closing, I'm now going to invite Dr. Praveen again, just to share a few closing thoughts on what are the couple of critical points he would like us to leave with as we come towards the end of our session today. So Dr. Praveen, maybe a few thoughts from you. Dr. Praveen, you are on mute. We may have a difficulty in connection. We have been very, very lucky so far. So let me not encourage my luck to run out. So I will close. I think it has been a wonderful session. And unfortunately, we have reached the end of our gathering. And really all that remains is that I extend huge thanks to all our panelists today for the time and commitment on MAMI, and to Professor Sinuel from UFAR, who shared his thoughts, but very, very much felt his presence and wonderful insights into what is happening in Ethiopia. Thank you to the government again of Japan, to the Irish Aid and to ECF for their invaluable support, to the ENN team for all the organising behind the scenes, to the interpreters for helping to improve access to this conversation, and to you all for truly heartening engagement in our MAMI session, which we hope will spark many more conversations and actions wherever you are in the world. And please, as Gronya said, don't keep these to yourselves. Share what you do with us at the MAMI Global Network so that we can continue to inspire and learn from each other and build evidence together. And finally, as you leave, take a couple of moments to fill in a short evaluation. And this includes a question where you can put in any suggestions for commitments and actions you have while they are fresh in your minds. So take care, Slán Abhaile, and safe home.